What a first session. I felt like the questions were coming at us so fast. I mean, we could have gone on for forever on that actually. Um, Everyone is there's people are starting to come into the room right now. I think we should just get into it. So I'm going to introduce all of the panelists. Once again, I'm Rich Dubin. I'm the founder and publisher of Lower Extremity Review magazine and the CEO of LER Expo. We have obviously Dr. Matthew Dobbs, who is the director of the Dobbs Clubfoot Center at Paley Orthopedic and Spine Institute in Florida. We have next to him on the top, we have Dr. Allison Schiffern, the pediatric orthopedic surgeon at Gillette Children's Specialty Healthcare. Next to her, we have Maureen Hoff, who's Clubfoot parent, advocate, author, and MD Orthopedics brand ambassador. Below her, we have Michelle Hall, a certified prosthetist orthotist at Gillette Specialty Healthcare. And then to her, I guess would be her right, would be Rosalind Owen, a senior physiotherapist and executive director of Global Clubfoot Initiative. And then we have at the right down there at the bottom is Karen Moss, founder and executive director of Steps Charity for South Africa. So we already have somebody wanting to grab the mic and come up to the stage, which I think is fantastic. So I think that Munir was trying to grab the mic a second ago. Yes? Yes. All right, so we're going to give Munir Earth the microphone to get him up to the stage and have a question. So they're coming up now.
Hi, Richard. Can you hear me?
Yes, we can hear you.
Yes. That's great. Thank you. Thank you. Thank you. Thanks to all of you for arranging these kinds of program. This is really helpful for us. Thanks. My question is, can I talk 2 minutes or 1 minute if you have no problem?
Yeah, go ahead. Ask your question.
Yeah. I can give you a history. I'm from Bangladesh. I'm from a small city, Chittagong, in Bangladesh. It's besides India. So my history is I have a 14 months child over here. He's left clubfoot by burn. So we started at the days 5 the casting over here in Chittagong and an orthopedist. He is very famous orthopedist. So after 4, 5, 7 days casting, the orthopedist asked for a tenotomy. So we went for a tenotomy. There are another 2 orthopedists also there, 3 specialists. So they said the left leg, and they said no need to tenotomy, just follow 23 hours BNB. So we followed 23 hours BNB until 9 months. After that, the doctor said that when he started working, come to us. So after that, March, April is come. The COVID is come. So everybody, we cannot follow up with any doctor. March, April, May, June, July. No doctor is. The COVID situation. Everybody was back in the home. So now, since last month, we saw the leg. The tendon is a little bit tight. A tendon is a little bit tight, but leg is strong. Leg is straight. Leg is okay, and he is walking. But left leg tendon is tight. Then right leg. So we were a little bit concerned. We worried. So we went for another opinion, another doctor who is sitting over there right now. He said he will. He asked us to follow 14 hours BNB. 14 hours BNB. Hello, can you hear me?
Yes.
14 hours BNB and the stressing 3 times a day, and he will see after 1 month, and then he will decide another tenotomy need or not. So, but he's saying that tenotomy may need. So my question is, why it's going to be relapsed, or how can we confirm that it's relapsed? How can we say that it's relapsed? Is this that only tendon a little bit tight, or we will wait another 1 or 2 months, or we will see? What should we do right now? if tenotomy is need, I have no worry. I'm just worried tenotomy should be done by a specialist. I mean, what I said. I'm worried about tenotomy. Is there any risk of tenotomy? Because there are so many nerve in the leg, right? So I'm just worried regarding tenotomy. And after tenotomy, what should I do? What should I do? That's my two questions. And why it's relapsed? Because I followed 14 hours BNB. I followed one-time stressing at night. So what did I wrong? I mean, what did I made the mistake? That's why it's relapsed. That's my first question. Second question is tenotomy. Is there any risk? Third question, what should I do? Thank you so much.
Okay.
Thank you so much.
Okay, Dr. Schifrin, you want to comment on that? Take your mic off. Unmute. There you go.
Sorry, I was midway through typing a response to another question. I might bounce to Dr. Dobbs and finish this response if that's okay.
Fair enough. Dr. Dobbs?
Yes, I'm here.
Okay.
So, I guess my first message to you is certainly don't blame yourself. It's nothing that you've done wrong. Clubfoot, wants to relapse. This is what you're fighting, the entire time. So, being tolerant and compliant with bracing and doing the stretching exercises, that's your role. That's what you should do. Some feet, relapse despite that. And if it's truly, I can't give you advice on whether you need a tenotomy without an exam, and seeing your child, or at least, videos and pictures. But if the motion is not there, and the heel is tight, then the answer is yes. You need a tenotomy, and that's better done earlier than later. And then it's obviously back into bracing and stretching. It's important, to get an exam, to make sure that this is, isolated clubfoot deformity. In other words, can your child move the toes? Some kids are weaker than others, so you want to make sure it's, everything is functioning normally. Because when things are weak, it puts you at higher risk for relapse as well. So my advice is obviously a good clinical exam. And if the tenotomy is needed, then I certainly would proceed with it.
Excellent.
Thank you.
Thank you, Monir.
Maybe Ross wanted to something.
Okay. And we have a whole slew of questions here. Jen Coxey, sorry.
So that was the one I was starting to type a response to. I don't know that I've seen any way to distinguish the severity of a clubfoot on a prenatal ultrasound. I see lots of kids referred to me with a prenatal diagnosis of a clubfoot that turns out to be metatarsus adductus or a positional clubfoot. I also see, a variety of severity after birth. So I don't know that that's something necessarily that I've been able to distinguish. I don't know if anyone else has experience in saying how severe a clubfoot would be on a prenatal ultrasound.
No. Okay. We want to, how about Michelle, you want to pop in on Dorothy's question about what age is relapse for clubfoot no longer an issue? Unmute. There we go.
I suppose I would probably defer more to Dr. Schifrin and Dobbs on this, but my understanding from when I worked with Dr. Ponseti, and I would love any correction to this, is that by age 5, most children have an adult foot structure. So if we can get them corrected and then keep them corrected by that point, we don't tend to see a relapse. But with that said, you can also do some corrections later, and we find that with some of the African outreach that my colleagues have done, and I'm sure Dr. Dobbs and Schifrin have better insights on that.
Either one of you want to pop in on that?
Well, sure. The bracing, I think you're exactly right. I don't disagree with anything you said. Nobody knows, the exact age to stop bracing. This is the age-old question. This is the reason I did that 10-year clinical trial. We're trying to get some clarity to this question because all club feet, again, are not created equal. And it more becomes an issue of muscle function. So some club feet, the kids are weaker than others. If you have a weak lateral compartment where you can't evert your foot very well, you're going to be at higher risk for relapse. It doesn't matter if you're 5, 6, 7, 8. You're going to have trouble, with that. So that's a constant problem. So, what you're hearing for numbers are averages. So if you take averages of isolated club feet and you make it to 4, you're going to do pretty well by numbers. Some kids need it longer, and that's the judgment of a clinician and with the parents, to make that decision on who needs to go longer. Some kids need a tendon transfer that may help that, at that stage, and some are weak enough where that's not an option. So the long-winded answer is we really don't know, the exact age where you need to wear a brace too, but we are getting better at it. And so with the stuff that we've done, we're going to have clinical exam features, and criteria you can do that helps you predict better. So you can prescribe, a more, a reasonable treatment algorithm for each patient.
Thank you, doctor. We have Ellen that asked about what is your opinion on footwear? Do you recommend specific brands or hand-me-downs okay? Do Maureen or Karen want to pop in on that one?
Sure, I'll jump in. I know personally from being a parent of a clubfoot child who is 2.5 now, we were really particular about the shoes that she wore. She has 2 older sisters, and I made sure that we didn't do any hand-me-downs just because I know that the foot molds to the feet, to the shoe. And so we were just particular about that. Now, my daughter's a current patient of Dr. Dobbs. So I asked him about this specifically in an appointment when she first started walking, because I was like, I need to make sure that she has shoes on and that nothing happened to her feet. And he was like, basically any kind of shoe that you get, that sneaker that has good ankle support is good. The one he said, which you can correct me if you're wrong, that he didn't like was Crocs, because they didn't provide a lot of ankle support. Now, personally, we found a lot of success in the Stride Right shoes. So I'll order those specifically. I just feel like they have very specific sizing. And my clubfoot one is she's got real small feet. So, winter boots and things like that we need to order, sometimes you can't find those in the size that's small enough to fit her feet. So that's the type of shoe that we've used, but we've had other success with other brands as well. But that's the one that I tend to go to.
Awesome. Thank you.
Rich, Dr. Ponsetti told us that actually he even wanted kids to run around barefoot because they get a good stretch. We always look for shoes with a bit of an arch, just to support that part of the foot. I think the worst ones for us were sort of Havana slops. I don't know what you call them in America. I think thongs, or those shoes that you slide your toes into, those that give the least support. And my son's feet used to get sore running around in those after a while. So, but otherwise, anything decent.
Yeah. Something with support and arch support and ankle support, to help with the biomechanics, I would think would be appropriate. We have a question from Dr. Barry Rothenberg, a CPO. Has anyone encountered an adult client who's developed a clubfoot as an adult with no known etiology? She has had surgery, casted AFO made, but her clubfoot appearance has returned. Would she be a good candidate for the Ponsetti method? How about Michelle? You could probably pop in on that one.
So I defer to, again, Dobbs and Schifrin on the casting aspect of it. But as far as molding that individual for a AFO, a ankle foot orthosis, that we would often do for our adult patients that present with Talipes equinovarus, so that clubfoot presentation that maybe has been acquired in adulthood, those people I've actually found, if I take my mold in a similar hand casting position to what our physicians on the call would do with our infants when actually casting for the Ponsetti method, I can actually get a lot more correction and get that AFO typically perhaps get the adduction corrected to more neutral, but the equinus might be persistent just because that Achilles is a hard one to manually manipulate. If it's where it is and it's tight, we might not be able to correct that as far as just taking a mold for an AFO. But again, with respect to the casting for Ponsetti, I defer to our physician.
Okay.
I don't feel like there's ever a reason to not try the Ponseti method, to be honest. I think there's very little downside. I think you get a pretty good idea within a couple of weeks of casting a patient whether their foot is going to have much of a response or not. But I think it's a non-surgical, minimally invasive way to correct at least part of the deformity. I can't say that I've had an adult show up that had a recurrence that we haven't found another etiology for, whether there's a peripheral neuropathy, whether there's a tethered spinal cord, spinal tumor. I keep looking and I keep finding things that surprise me. So I don't know that I've ever seen a patient that just had a spontaneous recurrence.
And with that, if I can add to it, I was just thinking about a lot of the adults that I see that have that kind of Tillepes equinovarus deformity. Sometimes it goes along, like Dr. Schifrin said, with other etiologies, like other diseases. But it may also, in adulthood, be corresponding to bone deformities. So as Dr. Dobbs had mentioned, with true clubfoot, the bones are normal. They're just misplaced because of the tightness of the tendons and the ligaments. Whereas when we get into some of the adult etiologies, we might actually have some bone deformities where we can't actually correct through manipulation, in which cases, surgery would be potentially needed if we couldn't get the person comfortable and stable with some sort of.
Gotcha. Roz, would you like to pop in on this next one from Lisa on what factors besides prolonged casting influence flat top talus? Can it be prevented?
Yeah, sure. But if any of the other panelists want to give an answer to that as well, I'd welcome their thoughts as well. But I think here, that it's really important that the casting is very accurate and is done in the correct way with the fingers placed in the exact place as Dr. Dobbs showed in his presentation, so that we know that the movements are really occurring in the joints and in the planes where we want them to be as the Ponseti manipulation is formed. When those manipulations are causing other types of movements or movements in different planes, that's when I would expect to see running into problems like flat top talus.
Okay. Awesome. Okay, we have Mary Lou Stillwell, physical therapist. How soon after kiddos come out of the cast can you start passive range of motion activities, and how aggressive do you recommend getting with the range activities? Anybody want to pop in on that one? Don't be shy. I'll start picking somebody. Let's go.
I think, really you can start passive range of motion immediately. If you're just doing gentle stretches of the foot, there's no contraindication to stretching the foot after casting. Most of these kids are transitioning into their foot abduction orthosis for 23 hours a day. So there's not a lot of time or need to do a lot of physical therapy immediately after casting, but I don't think there's a problem with starting stretching right away. And sometimes stretching and massaging the foot can help it to be less sensitive when you're transitioning into the bar and the shoes.
Awesome. I mean, the questions are just coming at us. So I want to also say that there are so many questions, and if we're not able to get to all of them in each of the sessions, then each of the panel discussions, then we will make sure to get the answers to those questions to the individuals that asked them after the event. So whatever questions we don't get answered, we're going to get to those after the event. So just, bear with us on this. Okay, so we have Nareen Smith, the parent. Is the prevalence of torticollis, GERD, and tongue in tie common in clubfoot babies? Do you see these issues with patients with club feet? Was this noted ever in any of the genetic pathway studies for PITX1? I guess that will go to Dr. Dobbs.
Sorry, yeah. So I certainly have seen all of these deformities with clubfoot, but I'm not going to tell you they're associated with clubfoot. So these occur in other children as well. And it was sort of the answer earlier with hip dysplasia also. You're going to find literature supporting things occurring, together, but it's also you'll find things supporting not a real correlation. And certainly with none of the genes that we have found, and we've found 5 genes for clubfoot so far, any of those things run together. But I think it makes the torticollis part makes sense to me that it would, because it's a contracture problem, right? So it's sort of, like clubfoot. It's like, we have some families that have clubfoot as well as toe walking in the same family. Same idea with a contracture of the heel cord. So it's part of a contracture syndrome. So, some of those things make sense, but it hasn't borne out in genetic panels that we've done so far.
Okay. Let's see. Our doctor is considering stopping nightly orthotic wear at age 2 because his feet look so good. He has a typical bilateral clubfoot and did not need a tenotomy. Feet are very stretchy to 30 degrees. Is this a good idea? This is from Alexandra Kravitz. How about Maureen? What do you? Or we should go with somebody pop in on that one.
I was just typing a quick response to that one also.
Yeah, good, Alice.
I struggle to tell any of my patients that they should stop at age 2, especially if they're having success with the use of the boots and bar. Even with flexible club feet, there is some recurrence risk. And I think it's a lot easier to keep going with boots and bar rather than take a break, have a recurrence, and then try to reinitiate use 3 to 6 months after stopping.
Good. Awesome. It's coming so fast. I'm trying to keep up. Okay. My son has bilateral club feet. Did Ponseti method, Dobbs bar as an infant toddler at 6 years old, bilateral tendon transfer and heel cord lengthening. We stretch on dorsoramp and do nighttime bracing. Can we do more to prevent relapse and build calf muscles? Anybody want to chime in on that one?
I just know as a parent that I have that question asked a lot, and I see that a lot in parents is there a way that we can build the calf muscle even in the clubfoot so that it becomes more like the non-clubfoot? And I know that the information that we received was that no, there isn't anything in particular that you can do to build the calf muscle, that it is like in Dr. Dobbs's presentation, it's a muscular difference. So no matter what kind of strengthening exercises you do, it's not going to build. I don't know if that's medically correct information. That's just the information that we received as a parent. And I think that a lot of parents ask that. It's not an issue that we have with ours because my daughter's bilateral clubfoot. So most likely she'll have very similar calves.
Can casting a small baby at birth, 5.5 pounds, cause poor outcomes long term? Dr. Dobbs?
Yeah, I can jump in here. It's not hard. It's easy to correct, actually, a small baby. That's not the issue. The trouble with casting at such a small weight is actually the bracing. So it's the shoe fit. And so if you cast a premature infant or one that's, I have a 7-pound, criteria. So if they haven't reached 7 pounds, I won't start treatment because I can't fit them into the shoes afterwards. So it's just a matter of holding. And so then you've got to do prolonged holding casts until the feet are big enough to go into a brace. And there's really no need to do that. You can just wait till they're 7 pounds, get the feet corrected. So quick answer is I don't cast premature infants. I don't cast babies less than 7 pounds because you can't brace them.
You see relapse in conjunction with growth spurts? Roz, you want to pipe in on that?
I'm happy to chime in. Growth is our enemy. I'll throw that in there with any sort of contracture problem. The bones grow quicker than the tendons. And so anytime you have a contracture, underlying issue, you're going to struggle through growth spurts, or it's a time where you have to be wary. And there's certainly a time to engage, your physio. You notice things getting tighter. You might pick things up on that end, but you do have to watch out during growth.
Exactly. I would really love for any of the parents or clinicians that are asking questions to grab the mic and come up to the stage and ask it in person. We'd love to see you. It's a little left-hand side. There's a little microphone. That would be awesome. We do have Monir grab the mic again. Let's see what he has to say. And there's just lots of questions coming in. Let's see. Monir's coming up to the stage to ask a question. If he's there. Maybe he dropped the mic. Okay. Great. We have here, can you comment on when it's appropriate to change the rotation of the clubfoot boot to less than 60 to 70 degrees? Is overcorrection an issue long term? Who would like to chime in on that one? How about Michelle? I'm going to tag you again.
Sorry, I was responding to a question.
I know. There's so many. It's coming in so fast. So can you comment when it's appropriate? Dr. Dobbs, you want to chime in on that?
Well, I'm happy to say something on that. It's, in general, the rotation doesn't change, during treatment for the most part. It's a great question. And so, one thing that Ponseti did when he came out of retirement and came, sort of training, the next generation of clubfoot practitioners was he changed two things in the method, and one was to increase the duration of brace wear. So he early on his publications, if you look at him, it was a 2-year process, and he, increased that up to the 4-year and even, 5-year in some situations now. And he also increased the amount of external rotation that he tried to get. And so that's where the 70 degrees came out of. The one issue with that that I can tell you is, again, that all feet are not created equal. And all feet cannot achieve 70 degrees. And I think this is actually a big problem with management and a big reason for early brace failure. So if you have your orthotist that is told to have the braces being given out at 70 degrees for the clubfoot side in every situation, that's not going to match, because every child did not achieve that. And so you're asking for a brace intolerance right there and non-compliance and trouble. So you have to match whatever you achieved in the last cast. If that's 50 degrees, that's where the brace should be. You don't turn it to 70. So I think it's a very, very important question. And to answer the other half of it, I guess, with, can you overcorrect? The only situation where I see this as a big issue is in your children with hyperlaxity. And so this is there is a patient population, clubfoot patients that are hyperlax. And you also have children like with Down syndrome or other connective tissue problems that can have club feet. They are prone to flat-footedness. So if you correct them to 70 degrees on a brace, yes, they're going to roll into a flat foot position. So it's really not ideal. So those patients should not be put at 70. They should be in the 40 to 50 range. And you have to identify that as a practitioner on where you should put things. So it's not one answer, 1 degree. You have to use some clinical acumen to figure that out. But
yeah. And to add to that, early 2000s, I think it was, we were seeing at University of Iowa a lot of kids with either unaffected side being very flat-footed, sure, or the clubfoot being almost, overcorrected in the sense that as they were older, they were very flat-footed. And I think that's where, when I started, we were doing the clubfoot side. If it was just 1 foot, it was 80 degrees outward rotation, and Ponseti had us start reducing it to that 60 to 70. That's kind of held for a long time. And similarly, on the unaffected side, we used to be closer to 60 degrees, and we've moved that down to 30 degrees. And that all happened, again, in that time frame because what we were seeing clinically. And I think, as we move forward, as we learn more genetically, as we learn more about bracing and the effectiveness of it, over time, we'll probably start to see some of these numbers continue to change. But it's really key that you're, whenever possible, working with an orthotist and your orthopedist very closely. So as an orthotist, I am working with like Dr. Schifrin at Gillette Children's, and she's, we're having these conversations about different challenges we might be having with particular patients, and then by her guidance, adjusting the orthosis based on the kid's presentation.
Awesome. And then we have another orthotic session coming as well. So they should be aware of that. All attendees should be aware of that as well. So Laura Van Kirk, Clubfoot parent, is grabbing the mic. So I'm going to give her the mic and bring her up to the stage. Ask her question. Laura's coming. Do you accept the mic, Laura? Oh, there it comes. Awesome.
Sorry, I don't know. Is it working?
Yes.
You can hear me. Okay. Yeah. So my question is for Dr. Dobbs. Hi, Dr. Dobbs. I was wondering about if you could go into a little more detail with the myostatin treatment. Is it age restrictive? Does it need to be done within a certain period of time? And what's kind of the route? What does that look like? I know you mentioned e-stim, but yeah, we would love to hear more about that.
Sure. The myostatin was a tease. So the myostatin that's not ready for prime time. This is, I always put sort of that myostatin in there. Sorry. Because I get to the end of a genetics talk. Most of the audience, whether it's or whatever, a little bit glazed over at that point. And so they're going, genetics, yes, so what? How does that affect us? How is it going to change treatment? And so this is where I put this in. And I mean, it is theoretical, but it's also, it is real. I mean, going toward things like this. But it's not ready for prime time in terms of being able to apply this clinically. We have done this in some animal models, but we haven't, done this in a clinical scenario yet. For prime time.
Okay. Yeah. Cool. Thank you.
Excellent. Anything else? Anything else, Laura? No? Well, thank you for coming up to the stage and asking a question. Appreciate it. Let's see. All right. You can just, there we go. All right. Oh. Let's see. We have another. Anybody else coming up to the stage? No. Okay. All right. Anyone else want to thank you, Laura, for coming up to the stage? We really appreciate that. Let's see. How can I deal with my child's relapse in his left foot if we exclude surgical intervention now? Not sure. Dr. Schifrin, you want to pipe in on that one?
Sure. Not sure what the specifics of the question are, but I think anytime I see a child that seems like he's had a relapse, whether it's an early relapse or a later relapse, you go back to the beginning of the Ponseti method with casting, and you do the series of casts to address that area of relapse. And then some kids, if they have a recurrent equinus contracture, then we'll discuss a revision Achilles tenotomy. Some of the older kids, tendon transfer. But I think for me, my first line is still the Ponseti casting technique for any recurrence, and then try to get back into the boots and bar.
Okay. I think that covered it well. So Monir cannot see the mic request. Monir, you might have to leave the room and then come back in. I think you're having some computer challenges over there. Are there any different protocols for different syndromic cases? Anybody? I chime in on that one.
I can jump in on that one as well. At Gillette, we see lots of kids with syndromic club feet as well as idiopathic club feet. And the initial technique tends to be the same. You have to be cognizant of pressure sores, issues in kids with myelomeningocele who have sensory differences. And then you can expect to get the same degree of flexibility in most of these kids that you would get in an idiopathic clubfoot. So for kids with arthrogryposis, you're not expecting the degree of abduction that you get with kids with idiopathic club feet. So I think the basics of the technique are the same, but your ultimate goals with the casting and then how you set up your abduction orthosis is different going in, after the casting phase.
Awesome. All right, we have Crystal Connerty, another parent requesting the mic. So we'll bring her up to the stage with us.
Hi.
Hey. Hi, how are you?
Thanks, how are you?
Welcome, absolutely.
I really appreciate this panel. My son has a bilateral clubfoot, and what we've been told by our orthopedic surgeon is that basically it's up to us when we stop using the boots and bar. And we're really, really nervous about that situation. We don't want to have a relapse. And from what I'm understanding from the panel, there isn't really a great time necessarily prescribed for every child, but it's quite a lofty decision to have on your shoulders as a parent to decide when to actually stop the boots and bar. So our son started the Ponseti treatment at 4 weeks old. He went through the casting. He had the tenotomies. He's been wearing the boots and bar. He did the 23 hours and then moved to just nighttime wear, so about 12 hours a night. And he's 38 months old now. So I guess my question is there anything that can be offered to us from the panel that can help us in this decision? Because it's a little challenging, as you can imagine. I should mention, though, that the reason why we were given the decision of when to do it is because his tendons are described as loosey-goosey. But I should say that the last 2 appointments were done via Zoom, so they weren't in person.
I'll leave that up to you. Anybody want to chime in on that? Go ahead, Dr. Dobbs.
Yeah, I'm happy to weigh in. Without an exam, it is hard. It's hard to give you, specific advice. I think, as was alluded to a little bit earlier, if you're in a situation where it's not World War III, and you've got a routine down, I tell my patients to go to the age of 4, 4th birthday, with an exam like you're describing. So if you truly have, good motion and so forth, and it's not World War III, then I would stretch it to the age of 4. If there's any signs in there that are, more worrisome than that, and it's not just the looseness, as we talked about earlier, loose feet can relapse. It's really a matter of muscle quality is more important than anything. So if you have weakness, if you have weak everters or weak dorsiflexors, you're more prone to relapse. So that would be sort of the more specifics on exam that I would want to know. But I think, getting to the age of 4 has sort of been the gold standard. And as I mentioned a little bit earlier, we are changing the paradigm on that based on a very large clinical study. So, based on exam findings. So, and it's not just muscle quality, it's foot circumference and foot length and calf ratios and things like that. We're going to be able to be more specific on telling you when you should stop. But I'd say without knowing anything else till the age of 4 is the safest thing to do.
Okay, that's what kind of our gut was sort of telling us based on some preliminary research had done. But when your son is complaining about his knees hurting and, you watch it, knees are in weird positions, it's a bit troubling. So thank you very much, and all the best to the rest of the panel.
Very welcome.
Thanks for coming up. Okay. We had a post on the MD Facebook page. Is clubfoot a disability? It is still seen that way because some end up facing challenges as they grow older and their feet don't allow some function. Some have to repeat surgery. Some feet have problems in cold weather. So do you believe of clubfoot as any of you or all of you? What are your feelings on that?
I think one thing we were saying throughout this is that no two club feet are really the same. They respond differently to treatment and they may have slightly different treatment outcomes. So I think it's very difficult to say that to define the condition as a disability, but certainly some people might experience disability as a result of clubfoot. And I think that also can depend on the type of treatment they have. Those that were treated pre-Ponseti, as Dr. Dobbs said, might experience higher levels of disability due to the types of treatment that they had. But it depends very much on their presentation.
Okay. Anyone else Maureen, you want to pipe in on that one?
I think it just depends, like what Roz said. I think that the word disability, it's interesting because when we first found out in utero that she would be born with clubfoot and we didn't have any experience as a parent, I was like, is this considered a disability? And most of the research I found was no, but I'd actually be interested to hear what Karen has to say since she sees people. I think it's more from my perspective, if it goes untreated for a long period of time, then it can be considered a disability, but a treated clubfoot, I don't think would be. But that's just my personal experience. So I wonder what Karen would think.
Thanks, Maureen. Yes, I agree that untreated clubfoot is definitely a disability. You can't wear shoes or walk properly at all, and it's very, very debilitating. I would say that a well-treated standard congenital clubfoot, I don't consider that to be a disability. My son's almost 18. He was treated by Dr. Ponseti, and he runs and plays sport and just has normal foot issues. I mean, I get sore feet if I walk for a long time. That kind of thing I don't think is a red flag. And I think generally the Ponseti method does treat clubfoot to the extent that you have, for all purposes, a functional foot that's flat on the ground. And that's really what the main thing we're looking for. I see many, many untreated children working in the clinics that I work in South Africa and surrounding countries, and that's a completely different story. Those kids are definitely disabled, although they can still be treated in most cases, unless they're really quite a bit older, then it becomes more complicated.
Yeah, makes sense. Okay, we have someone requesting the mic. Come up to the stage. Bring that person up now. Okay.
Hello.
Hello, how are you?
Good, thank you. Thank you for arranging this panel for us. I have a son, he's 8 months old, and he was born with one foot, the right foot clubfoot. So we had a treatment, and he's wearing the boots and bars at night time for the 12 hours. So my question is, he's crawling a lot, without a without the boots and bars, and even with the boots and bars. But even at the night time when he's wearing the boots and bars, he tried to hold the crib and try to walk, even with the boots and bars. Is it okay to allow him to do that? Because without the clubfoot, without the boots and bar during the daytime, he do hold the stuff and try to walk, but he's doing the same thing with the boots and bars. So in this situation, what should we do? Should we allow my child to do that, or just stop him doing that, or how it's affect his feet?
I'll let anyone speak to that one. How about?
I would say it happens. Go ahead.
Go ahead, Michelle.
I was going to say it happens quite frequently for kids as they get older. The only caution would be, the risk of falling and injuring himself if he is attempting to walk. But I think the reality is if he's in them and he's getting up, say in the middle of the night, he's probably going to figure out pretty quick to start crawling. But I would love the insights from anyone else.
I just want to say that we've experienced that completely as our daughter tries to do that all the time. So as long as she's in them and not fighting them, then I kind of let her figure it out. If she needs to stand up in them, she does, just as long as she's not putting herself in danger, having.
Okay. Thank you.
Excellent. Well, I think we have another parent that wants to grab the mic. I think we'll do this mic, and then we'll go on to Karen, your presentation next. After we'll let Jessica, and then anybody that has a question, we can keep those questions and hold those for the next panel. I mean, this is only the first panel, so we have a few more of these to go. Hello, how are you?
Hi, I have a question about my son is 4.5, and he was born with bilateral club feet. And recently we had a Zoom meeting with the I think the physiotherapy at Hospital of Sick Children in Toronto, and they said that his heel is kind of protruding out, and that's why he has to keep wearing the boots and bar. And then I was wondering, is it the way we're putting them on that's causing this? He has pretty small feet, and the heel kind of protrudes out a little bit. Is it is this typical, or should we? Is there something else we could be doing?
Would you like to go with that one, Dr. Dobbs?
Sure. What I'm gathering you're describing, and I sort of need a picture to sort of look, but it sounds like the hind foot still has some varus. So if it's rolling out a little bit, it sounds like you're being told that the foot's maybe not, quite where it should be, and so to keep bracing. And again, I don't know for certain without seeing the foot, but there's nothing you're doing wrong. You're wearing the brace, and certainly you do want good fitting shoes on the brace. The foot's not sliding around. You want it to fit well in the shoes. But if the heel's really rolling out, I mean, it's going to become a question for you whether the foot is fully corrected, and whether you're going to need more treatment to gain correction rather than just wearing the brace. Brace is not going to get you out of hind foot varus if that's what the problem is.
Did you say hind foot varus?
Yeah, that's what it sounds like. That's what you're describing. The heel still rolling, to the outside. We call that hind foot varus. So it's part of the clubfoot deformity. It's just one aspect of it.
And how does that get corrected? Sorry.
It's usually, as was alluded to earlier, everything is starting with repeat casting. So you try to regain correction with serial cast. In some kids, if things are too tight, you may need some surgery, but it's usually we try to recover those with casting alone.
Okay. And at what point would I know this? Because right now he's 4.5.
Yeah, that's a conversation to have with your physician. And I know it's hard in COVID times, I know, trying to do the Zoom, visits and things, but that's a conversation to have with your physician, to see if they can, look and either even videos and get back on what their treatment strategy would be.
Okay. Thank you so much, Dr. Dobbs.
You're very welcome. Thank you, Jessica. Thank you for coming up. All right. So I think we're going to end this session, move on to the next room. We have Karen's 15-minute presentation, and then we'll be back on as a panel. And so everyone that's in the room, you can just exit the room and go into the next session, and we'll see you there in a minute with Karen and her presentation. And then any questions that were not answered in this panel, we will get to the questions. If we weren't able to get to them in the next panel, we'll get to them after the event as well. So we'll see you all in a couple minutes.